Welcome to Docs on Call, brought to you by Northeast OBGYN.
Good evening. I'm Elizabeth Nolf McDonald. 15% of American couples experience difficulty getting pregnant. What are the common causes of infertility, and when should we see a doctor or a gynecologist? Well, tonight, Dr. Christopher Stroud from Northeast OBGYN will answer those questions, more questions, and your questions. Welcome to Docs on Call, and welcome to you, Dr. Stroud.
Thank you. It's a pleasure to be with you, and it's a pleasure to talk about such an important topic. You know, I don't think there's anything much more exciting than when a couple learns that they're pregnant. At the same time, there are a few things that cause more anxiety and distress than the inability, or at least the difficulty, to get pregnant.
It must be a devastating feeling.
Yes, I mean, it can actually ruin, if not rule, people's lives. And as you mentioned in your opening remarks, 15% of couples. I think that strikes a lot of people as being very high.
I'm thinking, I do not know of any couples who have told me they're infertile. Good reason exists for that, probably.
Well, a good reason in that it really is a disease of silent suffrage. It's certainly not the thing that people are going to talk about in a casual setting. But certainly we see many, many people every day that are struggling with this.
Now, tell us, what is infertility and who suffers from that?
The definition that we use in medicine is really as a function of a woman's age. So if she's less than 34 years old, we say that infertility means the inability to conceive after 12 months of contraception-free regular intercourse. We change that definition slightly for the woman that's 35 and older, and we say after 6 months.
And why after 6 months for women 35 and older?
Certainly, with infertility, or subfertility as some would say, time can be the enemy. And with age, with each ensuing year, the natural fertility rate begins to decline. So we don't want the woman to wait longer than 6 months if she's over 35 before seeking help.
Subfertility, I've not heard that. That might be a more accurate way of defining this than infertility, because after 12 months a person might think they are not infertile, but sub might mean something else is happening, not at the extent it should.
You're exactly correct. Very good.
Can you define the time when women are fertile?
Yeah, I think this creates a great deal of confusion with the patients that I see regularly. The way we describe the cycle is based on 28 days. We label the first day, or cycle day number 1, as the first day that a woman sees appreciable menstrual bleeding. If we start counting on that day, on or about day 13 or day 14 is the day that the ovary releases the egg, or that's ovulation. So a woman is most likely to conceive around day 13, 14, 15, or 16. That's the highest fertility window in the 28-day cycle.
What if a woman has a 2-day period or an 8-day period? Does that in any way affect when she ovulates?
Not necessarily. We start counting, as I said, on that first day of bleeding. And the average is around 5 to 7 days of bleeding. Some women are blessed with a short number of days of bleeding. Other women suffer with a longer period. The critical point, though, is the time from the first day of bleeding until that day 13 or 14.
Now, if women think or believe they're infertile or subfertile, is it because their window of ovulation might be shorter or smaller?
Actually, when we think about the common causes of subfertility or infertility, it's really helpful, I think, to break them into common categories. The most common category, or about 30% of couples, it's going to be a female-related issue. In about 30% of couples, it's going to be a male issue. And then there's a small percentage that's combined male and female. And then there's a smaller category of unknown that we can't label male or female. If we think more about the female, I am, after all, a gynecologist, those categories we break into problems with ovulation, the eggs not being released either at the appropriate time or maybe not being released at all. Then we think about structural abnormalities. Is there something structural that's in the way? Endometriosis has blocked a fallopian tube. Maybe there's a birth defect and there's a wall or a septum in the uterus, or other problems that would prevent the union of the sperm and the egg. Then we think about male factor infertility. Is there a low or an absent sperm count in the male? Those are some of the major categories that we try to discern when we're helping couples look through this problem.
I'm surprised you said 30% male, 30% female, and then 30% both, because my thought would be most of the time it would be the woman. And as you explained, it seemed like many more things could go wrong with the female body.
You're right, and certainly most of the husbands of the patients that I see would agree with you. In fact, almost universally men will say, well, it's certainly not me. But in 30% of the cases, it really is. So one of the very first things that we do in the planned evaluation of the subfertile or the infertile couple is let's determine, is there a male factor involved?
And how do you do that?
With a semen analysis.
Okay.
It's a very simple, easy test. Typically it can be run at most laboratories. That'll tell us, is the count normal, are the sperm normal, and all of those pieces of information that we need.
And if you have a question, I'd like to encourage you to please call 483-8331, and Dr. Stroud will very eagerly answer your question. You were talking about male infertility. When a couple goes to the doctor, how soon do they know who is the person who has the problem?
Well, certainly the semen analysis can be done, and we have that answer very quickly. In a matter of 1 to 2 days, we'll have that answer. If then we know that the semen analysis is normal, then it's important to take a systematic and planned approach to determining, is there an ovulation problem or is there a structural problem? Since ovulation problems are the most common, that's where we typically look first. And that can be determined relatively easily. We'll often do a blood test on a certain day in the cycle to check a certain hormone level, progesterone specifically, and that will tell us if the woman is ovulating. We may do an ultrasound at the same time to look and actually watch the follicle develop and see that it's developing appropriately and at the right time. Once we know if a woman is ovulating and when she's ovulating, then if we know the semen analysis is normal, then we can send the couple off to do what we would call timed intercourse, where we know that you ovulate on a certain day, and we would plan intercourse around that certain day.
Is it a certain time in a certain day? Could it be the 24 hours? Or I've seen stories, I've known people who have said, called their husband and said, dear, now's the time, get home right away. Or is that just for the drama of a television show?
Well, it helps with the drama of a television show, but the reality is it's a window of opportunity of about 3 to 5 days. What you're actually describing are home ovulation prediction kits. And there's actually kits on the market. They're typically in the drugstores next to the pregnancy test, where a woman can test her urine, and it'll help define that window of ovulation.
Does emotional stress and trauma impede fertility?
You know, that's a good question, and I think it's one that we hear frequently. Stress per se wouldn't change fertility, but what stress makes us do or not do can certainly impact our fertility. If stress has us not sleeping enough, not eating properly, maybe doing other kinds of unhealthy activities as a result of the stress, then stress could play an indirect role.
And I've known couples who have been infertile, have adopted, and then have conceived. Many couples like that. So I think that's an alleviation of the stress, right?
Yes, I think one of the important takeaway points from this discussion has to be that the numbers are with you. The overwhelming majority of couples will eventually go on to conceive, and that's something we can hold on to as positive.
I also saw on television just last week a women's support group for infertility, and the people who joined it had a higher success of conceiving because their emotional levels were being met.
That's very interesting. Certainly we know that as patients begin to confront this problem and really understand their cycle, understand fertility, we see success.
Good. Leslie has a question for Dr. Stroud. Go ahead, Leslie.
Yeah, hi. How are you doing tonight?
Fine, thank you.
Yeah, I was just wondering, I was using contraceptive before, and I was using the Depo-Provera shot. I was just wondering if it can affect your bones, because I've had like 2 breaks, and they're serious breaks, and my bones aren't healing as far as my femur bone. And I'm just wondering if the Depo shot can affect your bones.
Sure, that's an important question. Thank you for calling. Depo-Provera is a progesterone form of birth control that's given as an injection, has to be given every 3 months. It's popular because it's very convenient, and it doesn't have to be taken every day, only every 3 months. To my knowledge, there are really no studies that suggest that Depo-Provera has a negative impact on a woman's bone or on her bone mass. So I don't think that's something I would look to as a cause of the problem that you're describing.
Are you really serious? Because here all along I thought it was. And then, so I was not going to even get my shot because I was convinced that's the problem.
Yeah,
all along.
I think clearly you need to address that problem that you're describing with your bones. But again, I don't think I would look to the Depo-Provera as the cause.
Okay, well, thank you very much.
That's my pleasure.
Okay.
Thanks for calling.
Thanks,
All right.
Leslie, for calling. Up next, Lois, you have a question for Dr. Stroud. Go ahead.
Dr. Stroud, years ago when I got pregnant, 6 other women got pregnant also, just by going to their OB/GYN doctor and taking thyroid and having that checked periodically. Also, I had my tubes blown out, my husband was checked, and finally I got pregnant. Now, why don't they do that anymore instead of all of this expense of going through in vitro?
Sure, good and important question. I think if I understand your question properly, you're saying why is thyroid level and having...
So important.
Yes, why is that so important? Excellent question. It's part of the category that I described of problems with ovulation. And untreated thyroid disease, interestingly, can affect a woman's ability to ovulate. One of the things that we see very regularly is we detect thyroid conditions that were otherwise unknown because we're looking for causes of problems with the cycle or of ovulatory problems. So it's a very routine part of an evaluation of irregular periods or certainly regular periods with infertility that we check thyroid function. And we'll pick up thyroid disease, treat that, and resolve the problem in many cases. I think the other
sorry,
test...
but I have never heard any young woman say that a OB/GYN doctor has checked her thyroid.
Well, that's interesting. I give you my word, we do all the time.
All right. Thanks very much, Lois. Kristen, you have a question. Kristen, do you have a question for Dr. Stroud? Okay. Sarah, how about you? Do you have a question for Dr. Stroud? Sarah? All right.
We've scared our callers away.
We have.
You know, the last caller mentioned that I didn't respond specifically. She mentioned having her tubes blown out or something similar. There is a test that we do that's called a hysterosalpingogram, and it involves injecting a dye into the cervix, and that dye then moves up into the uterus and then out into the tubes, and it's a dye that shows up on X-ray. And then when we take an X-ray while that dye is being injected, we can see what we call spillage of the dye out of the tubes. It's a way to determine if the tubes are in fact open or are they somehow blocked or another. There is some evidence to suggest, and there's certainly anecdotal evidence to suggest, that after doing that test alone, we see women's fertility rates increase. The feeling has always been maybe there is debris or something blocking the tube, and that test treats the problem. Hard to prove that, but it's certainly something that we seem to experience.
Good answer. Shaniqua, what would you like to ask Dr. Stroud?
I would like to ask him that when you are conceiving a baby, is it from any other parts that, like, when you're born, is the fertility of the baby, like, for the kidneys, anything to do with, like, when you first conceive?
I'm sorry, I had a little trouble hearing you there. If you could repeat that.
When you first conceive a child, does the development of the kidneys have anything to do with the baby at all?
If I understand your question, you said when you first conceive, does the development of the baby's kidney have anything to do with the baby's fertility? Is that what you're asking?
Yes.
Okay, good.
Well, certainly if there was a problem in the development of the kidneys, that may mean there are other problems in the development of the baby as well. So I think, you know, we could imagine a set of circumstances where there was a developmental issue with the urinary system and the kidneys and the bladder, and there may be also a developmental problem with maybe the female infant's uterus or tubes or ovaries. So in an indirect way, I think the answer to your question is yes.
Thank you, Shaniqua.